Pain syndromes in children form an important cause of referral to pediatric rheumatology clinics. They are not really well defined, not well recognized, and it takes time to take a detailed history, rule out other causes, and to convince parents that this is the diagnosis and there is no need to do further investigations. It can happen at any age, but more commonly seen in late childhood or adolescence, and more common in girls when compared to boys. Pain syndromes may be diffuse or localized. The diffuse pain amplification syndromes are known as childhood fibromyalgia and can be diagnosed based on the Eunice and Massey criteria of widespread pain, absence of underlying condition or cause, normal laboratory tests, and 5 or more typical tender points on palpation, along with the minor criteria. The more localized complex regional pain syndrome is diagnosed based on the presence of an initiating noxious event or immobilization or nerve injury. And there is, in such cases, we find there's allodynia. That means something that should not cause pain causes severe pain, or hyperalgesia, where the pain is disproportionate to the inciting event, along with changes of autonomic dysfunction, such as edema, coolness of the limb, or changes in the skin blood flow. And of course, other causes have to be excluded. So the etiology differs significantly from those in adults. What is important to remember is that there is almost always an underlying mental health issue or psychological distress. So the pathophysiology in localized regional pain, there may be increased sympathetic nervous system activity, but in diffuse pain or fibromyalgia, it is mainly due to the underlying psychological cause. A detailed history taking is very important, including social, psychological history. It's important to ask for any major recent life events, any school stresses, bullying by peers. There may be family history of similar complaints in the mother. And even as we take the history, we need to look for some clues such as interdependency or enmeshment. That means when we pose a question to the child, the parent answers. Sometimes they come with symptoms of conversion, such as sudden onset blindness or pseudo seizures. Eating disorders and poor sleep issues are common. And typically the family comes with a thick file, but the child is either having a look of indifference, what is called labile indifference, or is even smiling. And these children are usually achievers or perfectionists. They're sensitive and emotional children and strive to please others, either friends or family. And on examination, we usually find that everything is normal, but it's very important to do a thorough general physical examination, a detailed neurological and musculoskeletal examination to rule out inflammatory causes. We need to look for signs of allodynia, hyperalgesia, autonomic dysfunction in the localized syndromes, and to look for the palpate the tender points of fibromyalgia in the diffuse pain amplification syndrome. And usually it is clear-cut based on history and physical examination, but definitely we need to rule out malignancy. Sometimes Fabry's disease can come with extreme pain in the extremities, distal extremities. So we need to look for the skin signs of Fabry's disease, the hyperkeratotic plaques, nutritional deficiencies. Vitamin B12 can come with neuropathic pain, and vitamin D deficiency can come with generalized musculoskeletal pain. Metabolic causes such as hyperparathyroidism, or hyperthyroidism. In localized pain syndrome, sometimes it's important to rule out CRM or chronic non-bacterial osteitis. Generally, no investigations are needed. In fact, they come with more investigations that are done, and we need to ask them to stop doing any further investigations. We need to make sure that inflammatory markers are normal, and a low positive ANA should not be really taken as significant. And the management of therapy is to restore function and to relieve pain. And these children respond very well to physiotherapy, to occupational therapy, and reference to a child psychologist who will start psychotherapy is what is needed. The course is favorable in children, unlike in adults, which is a good thing, although relapses may occur during periods of stress. It is important to review the child, the family, to interview them individually, the parents separately, the child separately, and to follow them up consistently to make sure that the child is following the physiotherapy, is following up with her child psychologist, and is showing good progress. Thank you.